multiple myeloma. My name is Manoj. I'm Senior Vice President with Intas Pharmaceutical. Globally, this is known by the name Accord. It's my honor and privilege to introduce the Program Director for this international speaker program. Next slide, please. None other than Dr. Ajay Bafna will be the Program Director. As known to all of you, Dr. Ajay Bafna is Director and Head, Department of Medical Oncology at prestigious Bhagwan Mahavir Cancer Hospital and Research Center, Jaipur, an inspiring oncologist with more than 23 years of experience. And you will be happy to know, and I'm sure all of us have read about it, he was also recently awarded as the Inspiring Oncologist of India by Economics Times, which happened as early as July 1st. He established the department in 1998 and has immeasurable contribution in making Bhagwan Mahavir Cancer Hospital and Research Center as one of the best cancer hospitals in India. I personally have learned a lot from his teachings and from his clinical experience. Sir, an honor and privilege to invite you as a program director, sir. Kindly take it forward from here.
Thank you, Manoj, for such a nice introduction. Uh, I welcome all the delegates on behalf of Bhagwan Mahavir Cancer Hospital and Research Center. It is situated in Jaipur. Our hospital is the only standalone comprehensive cancer center in the whole state of the Rajasthan. So it is in 24th year of its existence, and it is called BMC HRC. So the BMC HRC is being managed by KG Kothari Memorial Trust under the able guidance of our chairman, Mr. Navratanji Kothari, and the impeccable administration by Major General Dr. S.C. Parikh. So they are the people who are running the show, and they have taken this hospital from scratch to one of the best center in the northern part of the country. We have all the facilities under one roof and a very good team of medical oncologists and hematologists also. And we are running the postdoctoral course also in medical oncology, that is DNB in medical oncology. So this is the flow of the program. So after my introduction finishes, then Dr. Manju Sengar will be speaking on top 5 changing myeloma papers during 2019 and 20, followed by advances in the treatment of newly diagnosed myeloma, and followed by our international speaker. She will be speaking on relapsed and refractory myeloma. I'm so happy that in the morning only I rang up Dr. Advani and he agreed to be part of this webinar. So he'll be the expert for this meeting and will be giving the expert comment after the Nupur Raji finishes her talk. Dr. Upendra Sharma is my colleague in Bhagwan Mahavir Cancer Hospital. He will be moderating the question and answer session. And after that, closing remark and vote of thanks will be given by Mr. Manoj Kumar. And I will now formally giving the introduction of our speakers. So for today's evening, the international speaker is none other than Dr. Nupur Raje. Dr. Nupur is the professor of medicine, Harvard Medical School, and she is also director of multiple myeloma program, Department of Medical Oncology, Massachusetts General Hospital, Boston, United States of America. And believe me, it's not very easy to catch hold of personalities like Dr. Nupur Raje. And on just by one email, she replied me back that she is very happy to be part of this webinar on multiple myeloma. So, you know, that is the greatness of this lady. I'm really hugely thankful to Dr. Nupur Raje. Dr. M.B. Agrawal, I think doesn't need any introduction. He is the teacher of teachers, and sir knows that I call him Dronacharya for all the students who are pursuing their course in hematology across the country. And all of us know that how much he has contributed in the field of hematology and especially educating the people in the field of hematology. I am really I'm really thankful to sir for charting out this webinar. He was very helpful to me. Sir is president of Mumbai Hematology Group, and he is also the professor and head Department of Hematology, Bombay Hospital Institute of Medical Sciences, Mumbai. And he is also a consultant at Lilavati Hospital and Beach Candy Hospital. I welcome you, sir. Next in line is Professor Dr. Manju Sanger, and whatever she says and whatever she speaks is so convincingly that everyone, she's really very sought after speaker as far as in the field of hemato-oncology is concerned. She's in the Department of Medical Oncology, Tata Memorial Hospital, Mumbai. I welcome Dr. Manju also. As mentioned earlier, Dr. Advani, he is my mentor, and I was there in Tata Memorial Hospital from 1995 to 1997, and he was my guide. And he actually taught me the intricacies of medical oncology. And I am also fondly being called the Dr. Advani of Rajasthan. So, this is a very great honor that people of Rajasthan give it to me in this state. I'm really thankful to sir. Whatever he has taught me, I'm practicing in my state. So, sir will be giving the expert comment. My colleague, Dr. Upendra Sharma, he is a consultant hematologist. He did his DM in hematology from KEM Mumbai. Dr. Upendra Sharma will be moderating the question and answer session. So there is a chat, there is a box of the question and answer session. It is different from the chat box. So you can put your question, whatever you want to ask from the eminent speakers, and they will be able to answer your possibly all your queries in the end. I'm really thankful to Mr. Manoj Kumar that the kind of help he has extended to me, and I am thankful to the INTAS Oncology India for extending all kind of cooperation in organizing this webinar on multiple myeloma. Last but not the least, I am profusely thankful to Mr. Rajesh Sharma of Mice Ideas for planning and executing the everything minor thing to make this webinar successful, and they have been cooperating me from the very inception for organizing this webinar. So this was all about the introduction, and thank you very much again from my institute, Bhagwan Mahavir Cancer Hospital and Research Center. So this is the time that I invite Professor Manju Sanger for her talk on the what she thinks is what the best papers during the year 2019 and 2020 in the field of multiple myeloma. I request Professor Manju to please start her talk.
Thank you, sir. Thank you for that kind introduction, and thank you for having me here. Thank you, Dr. Agrawal, for extending the invitation to participate in this exciting webinar. What I'm going to do in next 15 to 20 minutes is to discuss 5 practice-changing studies in the field of multiple myeloma. And what I have done is to focus on the major meetings in last 2 years, that's in 19 and 20, that's ASH 2019, ASCO, and EHA, to just cover the spectrum, starting from newly diagnosed multiple myeloma to post-transplant therapy to transplant ineligible multiple myeloma, as well as relapsed refractory myeloma. There is a lot of exciting things happening in the field of multiple myeloma. So I'll begin with the study, the most talked about study of the year. That's the Endurance trial, phase 3 trial, comparing carfilzomib versus bortezomib, in addition to lenalidomide dexamethasone in newly diagnosed multiple myeloma. This is a study which was in individuals who are being planned for deferred transplant, meaning being planned for transplant at the time of progressive disease. They did not include high-risk multiple myeloma, and the reason probably was that one of the acceptable induction regimen for high-risk multiple myeloma was KRD, and therefore randomizing these patients would become difficult. So they just wanted to look at standard risk multiple myeloma and what's the best induction therapy, whether it's combination of bortezomib with lendexa or carfilzomib with lendexa. So that was their first endpoint, and for that they were looking at progression-free survival after the induction regimen. A second very important question which the study is addressing is whether lenalidomide maintenance for a fixed duration versus a continuous maintenance is important, and the endpoint there is overall survival. They compared 12 cycles, that's 36 weeks of VRD with 36 weeks of KRD, that's 9 cycles of KRD. And they looked at second interim analysis in Jan 2020 in terms of progression-free survival. If we look at the patients, almost 1/3 of the patients were more than 70 years. And if you look at, they were relatively well-preserved patients, almost close to 80 to 90% of patients were performance status 0 to 1. 1114 translocation was present in around 20% of patients, as well as 414 was there in roughly around 10% of patients. If you look at this study, you can see both graphs for both KRD and VRD are merging with each other. And there was no difference in progression-free survival at the median follow-up of 29 months. When they looked at patients who were more than 70 years, though there is no statistical difference, but VRD seems to be doing a little better as compared to KRD. And when they censored patients who underwent transplant, despite the plan was deferred transplant, some of them did undergo stem cell transplant. And when they censored these patients, still there was no difference. And same way, though the data is not mature, the 3-year overall survival was not different between the two arms. If you look at the response rates, the interesting thing is that if you look at the VGPR or better than VGPR rates, they were much more in the KRD arm as compared to the VRD arm. Still, there was no difference in progression-free survival. One thing I just want to highlight here, the VRD CR rates, if you look at the stringent CR rates or the VGPR rates, are very similar to what was seen in SWOG study, which established VRD as induction regimen. But if you look at the KRD arm, where the CR rate and the VGPR rates, they look little less as compared to what was there in the phase 2 data, as well as the Forte trial, where the stringent CR rates were almost close to 50% and above with KRD 12 cycles, not 9 cycles, but 12 cycles. So this looks little different. The other important thing is the side effect profile. So as expected, they used bortezomib on twice weekly schedule, day 1, 4, 8, 11, and it was IV. Therefore, the peripheral neuropathy was much higher in this age, in this particular subset of patients who received VRD. And on the other hand, if you look at the KRD arm, there was much more incidence of cardiopulmonary events. So almost 16% total. And if you look at the grade 3, it's almost 12%. So statistically quite significant cardiopulmonary event. Again, the rates which were much higher as compared to what we have seen from the earlier phase data or from the relapsed refractory myeloma studies. So the conclusion of this study is that in the deferred ASCT setting, in patients who do not have high-risk disease, the permitted ones are the intermediate risk. KRD does not improve progression-free survival as compared to the VRD. What we don't get from here is what is the reason why the higher VGPR rates have not translated into the better PFS, and what is the reason why the study has little higher cardiopulmonary toxicity reported as opposed to the other earlier studies with this combination. Moving on to from endurance, we move to stamina, and it does need stamina and endurance to run these trials. One very important thing which I forgot for the endurance trial, that for the first time I've seen that they have done a triplet versus triplet comparison, and it was an investigator-initiated trial. Typically, the registration trials in myeloma, all along what we have seen, it's a comparison of a doublet or a triplet versus triplet or a quadruplet versus triplet. It's never been a head-to-head comparison of a regimen like VRD or KRD, what we have seen. So really, really a very important, a landmark study which has answered a very important question that in non-high-risk patients, those who are 414 or standard risk otherwise, VRD still remains a standard of care in terms of induction regimen. We are awaiting answer regarding len maintenance. A part of that answer has come from the stamina trial, and this is the trial which we have the long-term follow-up data here. So this was again a randomized trial done in transplant eligible patient, both high risk as well as standard risk. What they wanted to answer, so induction regimen was any. What they wanted to answer, what's the best post-transplant regimen, whether it's transplant followed by consolidation, whether it's transplant followed by maintenance, or it's transplant followed by a second transplant. all patients did receive lenalidomide maintenance. And the primary endpoint for the study was progression-free survival, which they wanted to estimate at 38-month endpoint. And this was published earlier in JCO in 2019. And you can see there is no difference in terms of whether you use only len maintenance or you do consolidation or you do second transplant in terms of progression-free survival. So you can safely just consider, only continuing with len maintenance. However, some interesting observation came from this long-term, study. One, that half of the patients discontinued lenalidomide maintenance at 38 months duration. The other half continued, and there was no difference in terms of different groups, whether they were in tandem transplant group or the consolidation or maintenance group. The numbers are almost similar, and same way it was similar in high risk and standard risk. So almost more than 2/3 of patients at baseline were standard risk and 1/3 were high risk. So discontinuation was very similar. So one, the long-term follow-up told us that even at the end of this long follow-up, the 5 years and the 6-year data, the progression-free survival and overall survival is not different in terms of different strategies what we use post-transplant. However, the study did stratify these patients as compared to in terms of standard risk and high risk. And when they looked at as per treatment, meaning when they looked at the per protocol kind of an analysis, the progression-free survival in the tandem transplant group was, or the double transplant group was much better as compared to the other two. So there is some suggestion that those who have high risk disease probably transplant a second transplant in terms of the post-transplant strategy is better as compared to consolidation and maintenance. The other important thing which came up from this study is the continuation of lenalidomide versus discontinuation. So as I highlighted earlier that almost half the patient discontinued lenalidomide at the end of 38 months. What you can see clearly that those who discontinued lenalidomide, they experienced an inferior progression-free survival as compared to those who continued. So the hazard ratio is almost 3.82, a significant difference, and this is very, very obvious in this particular graph. However, what is important to highlight here that the difference was maximum when we looked at standard risk. So what it means that people who have standard risk disease post-transplant, if they discontinued lenalidomide after 38 months, their progression-free survival was inferior as compared to those who continued. As opposed to that, it did not affect the high-risk group that much. However, having said that, there was no difference in the overall survival between the groups. So as I showed in the endurance trial, the second question which they are asking is the duration, fixed versus continued lenalidomide. There is some suggestion that in the group which the endurance trial is looking at is where the continuous therapy is probably better as compared to stopping lenalidomide. However, we need to look at that data as it matures, because in stamina trial, in the current trial, the induction regimen was variable. People use doublet, they use non-bortezomib based induction also in almost 20% of patients. So therefore, we need to now look at the endurance trial and get this answer regarding duration of len maintenance. The third study is we move towards non-transplant eligible patients, and this is the ALCYONE study, and again this is a long-term follow-up data. So the ALCYONE study addressed transplant ineligible, newly diagnosed multiple myeloma, who were stratified based on the age as well as the region, European Union versus others, as well as the ISS. What I want to highlight here that the comparison was daratumumab with VMP. Both arms received 9 cycles of this combination. Then the DARA VMP arm continued to receive DARA maintenance. And what they wanted to look at is progression-free survival. That was their primary endpoint. And the secondary endpoint, one of the pre-specified interim analysis, they said that they are going to look at the OS once they have 209 events. I always find this comparison very unfair that when one arm continues to receive therapy versus other arm receives the fixed duration, and we look at the progression-free survival. If we are continuing with active therapy, I'm not really sure progression-free survival is the right endpoint there, but that's my question and it remains in my mind always. So let's look at this data. So if you look at the patients here, they were, almost 30% patients again were more than 75 years. You had these performance status, again, almost 1/4 who had performance status 2. You can look at the ISS again, almost 40% in both arms had ISS3 disease, and roughly 20% or so had high-risk cytogenetic profile. So keep this in mind when we are interpreting the analysis. So this was the first publication from this study, which came at a median follow-up of 16.5 months, published in NEJM. And you can see clearly that there is a difference in progression-free survival between the daratumumab and the Dara VMP versus VMP arm. So which was not very convincing. But if you look at this progression-free survival data here, which is at 42 months, and you can see that the later half, after the 9 months are over, that's a phase where only daratumumab was continuing, and you can see that the graph is continuing to separate. So this is 48% at 42 months as opposed to 14 months. And if you look at what happened as they continued daratumumab in form of maintenance, the responses deepened. So if you look at earlier follow-up, the overall response rates remained the same, 91%, 91%, but the CR and the stringent CR rates improved over a period of time. And so the MRD negativity. So as the time passed, the number of people who achieved MRD negativity, it became much higher in individuals who received Dara VMP as compared to those who received only VMP arm. The other advantage of achieving MRD negativity is that those who achieved MRD negativity, they experienced much longer PFS in both arms, both in VMP arm as well as in the Dara VMP arm. The other thing which this long-term data highlighted, that the pre-specified analysis showed that not only just the PFS is better with Dara VMP, it's the overall survival which is better. So it puts to the rest the question or the thought that it's only the continuous therapy which is improving the progression-free survival. It's improving even the overall survival at the median follow-up of 40.1 months. So something to look forward for those who have who are non-transplant eligible elderly individuals who are going for induction therapy using Dara VMP makes sense. But it does come with the side effects. So there was relatively higher chance of infections, cytopenias in the patients who had received Dara VMP as compared to those who received VMP. So we have discussed the newly diagnosed multiple myeloma. Now we move towards the relapsed refractory multiple myeloma. And this was a late-breaking abstract in the ASH 2019, carfilzomib dexa along with daratumumab, comparing it with only carfilzomib dexamethasone. Here, the comparison in patients who received at least 1 to 3 prior therapies and have had at least partial response to 1 prior therapy. And the therapy was 32 months and 2:1 randomization in patients who are receiving carfil dexa Dara versus carfil dexa. And primary endpoint being progression-free survival. If you look at the patient profile, significant number of patients here are less than 65 years. So almost half of them are less than 65 years. Almost, close to around 80% of patients were ISS1 and ISS2. And if you look at high-risk abnormality, this is very much representative of what we see in this subgroup. Almost 15% were high risk. What is important here is that more than 2 lines of therapy patients who had received more than 2 lines of therapy were almost half in both arms. Bortezomib and lenalidomide were the treatments used in patients who had, so if you look at 92% of patients in the daratumumab arm had received bortezomib, and almost 1/3 were refractory to bortezomib and lenalidomide in both arms. So this is the subgroup where this particular treatment was used. And the PFS was much better in the Dara arm as compared to carfilzomib dexa arm alone. What is interesting here to see is that this particular triplet benefited individuals who had ISS 1 or 2. It benefited individuals who had good performance status, those who were younger, less than 64 years, those who had standard risk disease, those who had more than 2 lines of therapy, those who had received earlier LEN, or those who were refractory to LEN and proteasome. So this is the analysis, and what I don't want everyone to look at only at hazard ratio. I want you to look at the 95% confidence interval, and wherever it's crossing more than 1, we need to look at with the pinch of salt. So the benefit was restricted to some groups. Some of it is pre-planned analysis, as they stratified the patients, but some of it is post hoc kind of analysis which they have done. So we need to think of, when we are using therapy in relapsed refractory myeloma, that what treatment has been given earlier, what is the kind of patient profile we are looking at, and then decide on treatment. If we look at the response rates, as expected, the overall response rates and the VGPRs were much better in the triplet arm as compared to the doublet arm. Again, the triplet came with a price. There were much more infections in the combination in the triplet arm as compared to the doublet arm, and rest was as expected with the individual agents. So if you look at this combination, it does improve the progression-free survival in relapsed refractory myeloma. We have to, think in terms of those that pre-specified group, the benefit was maintained, but as we saw the analysis, we need to restrict probably its use in only those individuals. And we saw deeper responses, much more MRD negative CR rates in triplet as compared to doublet. And what is very important, that we need to select our patients. So those who had higher therapy, those who are elderly and frail, they experience much more toxicity here, which was fatal, and infection being one of the common problem there. Moving to the last but not the least important paper here, that's the CAR T-cell therapy in multiple myeloma. And this is the phase 2 KARMA trial with the ID cell. So this is the same CAR T-cell data which Dr. Raj's group published in NEJM 2019, the phase 1 data, that's BV2121. It's again directed against the BCMA, as most of the CAR T-cells are in multiple myeloma. And this particular study, which was the phase 1 study, showed that if you used cell dose of more than 150, it resulted in better PFS. So this was the study, again, a phase 2. After getting an idea that it works in phase 1 trial, the study was looking at overall response rate in patients who were heavily pretreated. And by a heavily pretreated, meaning they have already failed IMiD, PI, and anti-CD38, and they were refractory to their last line of therapy. What they wanted, that at least 50% or better overall response rate should be there, and then this therapy is acceptable. And with that premise, the trial was started. And as you can see clearly, that majority of the patients were refractory to anti-CD38, or they were triple refractory. So really a bad subgroup in terms of how they have done with their prior treatment. If you look at the overall response rate in this group, the overall response rate is 50 if you look at the lowest dose, but if you look at the 450 dose, it's almost 82%. And the time in which they could achieve this response was as low as 1 month. So they have crossed their predefined endpoint of 50%, and therefore this looks much more promising. If you look at the toxicity which you worry in CAR T-cell, that's the cytokine release syndrome and neurological toxicity, this seems to be much more tolerated. Even at the dose of 450, it's only 6%. If you look at 300, it's around 3%, grade 3 CRS, which they saw. If you look at the neurological toxicity, again, as the dose increases, around 450 and 300, it was more as compared to 150. So something to look forward to in terms of the triple refractory, as well as those who fail all lines of therapy, including an anti-CD38 in future. So with that, I would just conclude that it's very important to look at the study design when we are interpreting the result. The comparator does matter, as we saw in the endurance trial. It's very important to carefully select our patients and implement therapy from individual trials, as we learned from the CANDOR trial. And CAR T-cell bispecific antibody drug conjugates, as they've come up in last ASH EHA, they look very exciting options for relapsed refractory myeloma, those who fail multiple lines of treatment. So with that, I thank you, and I think we'll have the Q&A towards the end of the talk, end of the session. Thank you.
Yeah, thank you, Dr. Manju, for excellent presentation and about the best papers which were there in year 2019 to 2020, and we have all learned a lot from your presentation. Dr. Advani has also joined us. Good evening, sir. Yes, we are really, sir, delighted to have you. Yeah, on such a short notice, you accepted our invitation. I am really obliged, sir.
Thank you.
So now I request Dr. M.P. Agarwal, sir, for his presentation on newly diagnosed multiple myeloma, newer treatments. Dr. Agrawal, sir.
Thank you. Good evening to everybody. Thanks to Dr. Ajay Bapna for conceiving this idea of this webinar. We're discussing myeloma, and I'm going to talk about management of newly diagnosed myeloma. We'll first talk about transplant eligible patient. And in that, we'll first talk about the standard risk. It is now clear that the treatment should be triplets. In standard risk patients eligible for transplant, give VRD as the initial therapy for 3 to 4 cycles. Follow it up with transplant and then LEN maintenance. In patients who tolerate therapy well and are responding well, another alternative is to give VRD for 8 to 12 cycles and go straight to the LEN maintenance and do not do an early transplant. However, in such patients, stem cells must be collected for cryopreservation after the initial 3 to 4 cycles of VRD, and transplant must be done at first relapse. We move on to the high risk. In high risk patients, especially those who have double hit and triple hit myeloma, at the moment the ideal will be a quadruplet. That is adding DARA to VRD. Give it for 3 to 4 cycles, and this should be followed by mandatory transplant, not optional. And then the maintenance should be bortezomib based and not LEN. It could be either bortezomib every 2 weeks or a low intensity VRD in which bortezomib is given every 2 weeks, LEN is given in the dose of 15 mg, and DEX in the dose of 20 mg per week. What exactly is double hit and triple hit myeloma, and what is high risk myeloma? For this particular treatment, all intermediate and high risk myeloma have been included for the high risk. So if you have genetic events like deletion 17p, T414, T1416, 1420, gain 1q, or p53 mutation, all of these should be treated as high risk myeloma. If there are 2 high risk factors, take it as double hit, and if there are 3 or more, take it as triple hit. We'll now discuss myeloma presenting with renal failure. In patients who present with acute renal failure, and if you are suspecting that this is secondary to light chain cast nephropathy, the treatment of choice will be VTD, including thalidomide, or VCD, including cyclophosphamide. This should be done in conjunction with plasma exchange or dialysis using high cutoff filter. Plasma exchange should be continued daily until the free light chain level is below 50 mg per dl, and then repeated as per need till chemotherapy becomes fully effective. We now move to patients with plasma cell leukemia and multiple extramedullary plasmacytomas. These group of patients may be best treated with chemotherapy-based protocol. You could use VDT PACE or VDT PACE-like regimens. This should be followed with autologous transplant, and then the maintenance should be with bortezomib-based therapy, which we have already defined. To fine-tune the dose and route, bortezomib must be given only by subcutaneous route and only once a week. The exception to that may be when there is an urgency of rapid disease control. This will nullify peripheral neuropathy. Dexamethasone should be 40 milligram once a week, which is called low dose dexamethasone. should be given once a week unless there is a need for rapid disease control. Now we move on to transplant ineligible patients. When we're talking about transplant ineligible patients, there could be a number of factors. The patient may be 70-year-old or he may be 90-year-old. He may have no comorbidities or he may have multiple comorbidities. And there may be many other issues. So the treatment intensity has to be looked into from the angle of its safety as well. Once again, it's triplets for all of them. What do I do for transplant ineligible patient? If they are standard risk, once again VRD. This time it will continue for 8 to 12 cycles because there is no transplant, and then maintain with LEN. If it's a high-risk patient, transplant ineligible, and if you cannot use DARA, you will once again continue with VRD for 8 to 12 cycles, followed by bortezomib maintenance, that is borte every 2 weeks, or the low-intensity VRD that we talked about. What's the place of melphalan in transplant ineligible patients? So although melphalan-based regimens have been extensively tested in past, we do not recommend them because they cause stem cell damage, leading to secondary MDS and leukemia. This risk could be significantly reduced by using cyclophosphamide, and it has been shown that this substitution is not inferior and it does not compromise efficacy. Manju just told you about endurance trial. Now, carfilzomib-based triplet in phase 2 were shown to be superior to bortezomib-based triplet. And the phase 3 data, which was presented in ASCO and EHA this year, opens your eyes that everything that is better in phase 3 does not always come out to be really a better drug. What happened with KRD, that in standard risk patient, it did not improve the response and it added to the toxicity. So just because it is a second generation, more potent PI, it does not mean that it gives you better results in a standard risk myeloma. However, that does not take away anything from carfilzomib if we are talking about high risk myeloma patients. What about frail patients? And what about patients who prefer all oral therapy? As I mentioned, that when we're talking about transplant ineligible patients, there could be somebody who is 85, 90 years old. So in frail elderly patients, one would prefer a reduced dose LEN of 15 mg and a reduced dose DEXA of 20 mg per week. For those who do not want injections at all, and if you can lay hand on ixazomib, that can be a reasonable replacement for borte, and you can use the IRD protocol. Now coming to daratumumab. So daratumumab based triplets. DRD is the combination to be talked about from Maya study. So newly diagnosed myeloma patients, this was an international multi-center randomized trial. Progression-free survival at 30 months was higher with DRD than RD, 70% versus 55%. MRD negativity was also superior, 24% versus 7%. Addition of DARA to RD reduced the risk of progression and death by 44% in transplant ineligible patients. Improved depth of response, including 2-fold increase in stringent CR and CR, and 3-fold improvement in MRD negativity was documented, and safety profile was almost same as that reported in relapse setting. This results into DRD as the new standard of care for newly diagnosed myeloma patient not eligible for transplant. So if you have a patient who can manage DARA, then the treatment will not be VRD, but it will be DRD. DRD therefore becomes an alternative to VRD. However, one must remember that unlike VRD, where the triplet was used for a limited duration, 8 to 12 cycle, DRD requires treatment with all the 3 drugs until progression. And that makes it very expensive in Indian setup. What about quadruplets? So, DARA-based quadruplets, ALCYONE study. The randomized trial showed superior progression-free survival and overall survival when DARA was added to VMP. However, contribution of DARA to the induction component could not be ascertained from this trial. And that's the publication 2 years ago of DARA with VMP. Stem cell therapy. Autologous transplant improves median overall survival in myeloma by 1 year, and therefore it's almost mandatory. Randomized trials have shown similar overall survival, whether you do it early, that is after 3 to 4 cycles of induction, or delayed, that is at the time of relapse as salvage therapy. A recent French trial is comparing early with delayed autologous transplant, where patients were treated with VRD and LEN was used for maintenance. In this, patients were randomized to receive VRD 3 cycle, followed by transplant, and then 2 cycles of VRD consolidation versus VRD 8 cycles and transplant reserved for the relapse. Both received LEN maintenance for 1 year. Significant improvement in PFS was seen as expected with early transplant, but this did not translate into overall survival. Based on these results, it is reasonable and acceptable to consider a delayed transplant in standard risk myeloma who prefer a delayed transplant because of personal reasons or logistic reasons. What about tandem transplants? Role of tandem transplants in 2020 remains unclear. In earlier randomized trials, an improvement in overall survival was seen by 2 studies, but other studies failed to show this improvement. More recent data from 2 more randomized studies were also inconclusive. In the trial conducted in Europe, an improvement in progression-free survival and overall survival was seen with Tandem in both standard and high-risk subjects. However, no survival benefit was seen in the US trial, either in standard or high-risk patients. The US trial is more likely to reflect the impact of tandem transplant in the context of modern therapy, number of these drugs which were not used in European trials. In conclusion, routine tandem transplant are not recommended at this stage. They can only be a part of clinical trials. What about allotransplants? Role of allo, including non-myeloablative, remains controversial because of conflicting results. There's high TRM of 10 to 20% and GVHD, and these are too high to be comfortable. So allotransplant remains investigational. It may be considered for a young patient who's got a high-risk myeloma and who is ready, who is willing to accept high TRM and an unproven nature of this therapy because it gives you a chance of better long-term survival. So recommendations about transplant to be summarized as auto transplant must be done for all eligible patients. In a standard risk patient, it can be delayed to first relapse provided the stem cells are harvested early in the disease. Tandem transplant is not recommended outside clinical trial, and allo remains investigational as a frontline therapy. Moving on to consolidation. Consolidation is a term used where you administer a short course of therapy made up of 2 or more drugs prior to starting long-term maintenance. The BMT-CTN trial had an arm that investigated the benefit of post-transplant consolidation therapy, followed by LEN maintenance versus direct LEN maintenance. In this trial, additional cycles of VRD were given as consolidation. They did not result in significant benefits. Unlike earlier trials, the BMT-CTN trial specifically isolated the effect of consolidation, and hence this is very compelling. In short, consolidation therapy after autotransplant is not recommended, and patients should proceed to standard low-intensity maintenance therapy. Coming to the maintenance. For standard risk myeloma patients, maintenance therapy is indicated following transplant in all patients. This is standard of care. In meta-analysis of randomized trial, there was a significant improvement in PFS and OS versus placebo or no therapy. However, LEN maintenance is associated with 2 to 3-fold increase of risk of second cancer, from 2% to almost 4.5 to 5%. Patient must be informed and counseled regarding this and monitored for this. Among patients who did not undergo upfront transplant, based on the SWOG trial, maintenance therapy with LEN should be considered for all standard risk myeloma patients with good performance status after 8 to 12 cycles of triplet therapy. What about high risk? Impact of LEN in patients with high risk is unclear. There was no significant overall survival. However, in a recent trial, which was not a part of meta-analysis, some benefit was shown. The recommendation will be bortezomib administered every other week, that is every 2 weeks, because it showed improved overall survival, including in patients having deletion 17p. So bortezomib-based maintenance is the preferred maintenance for high-risk patients. It could be bortezomib every 2 weeks or low-intensity VRD, which will capture the advantage of both borte and LEN. Lastly, again, patients who do not want injectable bortezomib therapy, oral ICSA could be an alternative, and it has shown benefit in a placebo-controlled randomized trial. What about the duration of maintenance therapy? Is it time-bound or is it infinity? It's not just the efficacy of LEN maintenance duration, but the side effects, which are important. So although the benefit of maintenance are established, we are not sure about the optimal duration. We do not have data which is convincing. And whenever you talk about very long-term maintenance therapy, you have to consider the cost, the toxicity, and the inconvenience. Many or probably all patients seek a drug-free interval. An ECOG trial is comparing LEN maintenance given until progression versus limited duration of 2 years. And the trials are also examining whether the duration of maintenance can be decided by the MRD results. So recommendation about maintenance therapy as of today: LEN maintenance for standard risk patient after ASCT is mandatory. LEN maintenance after 8 to 12 cycles of VRD in patients who do not receive transplant is also almost mandatory. Maintenance with borte alone or low intensity VRD will be the state of art for high risk multiple myeloma. Smoldering myeloma. What exactly is smolder? To burn slowly with smoke without flames is the Cambridge Dictionary definition of to smolder. So you have a myeloma which is not flaming, but just smoking. Smoldering myeloma is a stage which is positioned between MGUS and active myeloma. So it's a very heterogeneous group. Some of them are really myeloma, which have not manifested overtly, and others are just pre-malignant MGUS. patients with smoldering myeloma have a risk of progression of 10% per year for the first 5 years and lesser later on. Those who were ultra high risk have been now included in the definition of active myeloma. I will not discuss this any further. So you're left with two groups, high risk and low risk. 25% per year risk of progression for the first 2 years is what happens when you've got a high risk smoldering myeloma. Now, presence of 2 or 3 risk factors is what makes the smoldering as a high risk myeloma. This is the Mayo criteria, and there are different criteria. We'll not go into that at this stage. Early studies in smoldering myeloma failed to show an advantage of preventive intervention. But these studies were not good enough because they lacked power, safe and effective drugs. Randomized trial conducted in Spain for patients with high-risk SMM showed significant prolongation of PFS and OS with RD, len with DEXA, compared with observation. There is a recent ECOG randomized trial which has provided additional confirmation of early therapy based on len, which prolonged the time to end organ damage in patients with high-risk smoldering myeloma. Based on these two trials, patients with newly diagnosed high-risk smoldering myeloma should be considered for early intervention with either len or len-dex. There is an ongoing ECOG randomized study testing whether a myeloma-like triplet, DRD, is superior to the prophylactic doublet. And also, there is a trial to look at whether these myelomas can be cured by intensive therapies like DARA, Kyprolis, Revlimid, and DEXA. So recommendation for smoldering myeloma is len or len-dex for newly diagnosed high-risk smoldering myeloma and all other patients to be observed without therapy. General management, I have no time to discuss them, but they are even more important than the specific treatment that we discussed. Infection prevention, role of vaccination, antimicrobial prophylaxis, and occasionally IV gamma globulin. Management of anemia, hypercalcemia, renal failure. Prevention and treatment of bone disease, role of bisphosphonates and denosumab. Controlling pain, including kyphoplasty and antithrombotic prophylaxis, aspirin, warfarin, or LMWH. What was hot in EHA 25 virtual or 2020 ASCO annual meeting? So the good news and the game changers were DARA, and DARA in upfront use of myeloma treatment. So what was there was the role of DARA in newly diagnosed multiple myeloma. And the summary of these cases, because I do not have time to go into the depth of this, is update on DARA-based triplet therapy, that is DARA, Velcade, Dex, or DARA, lenalidomide, and Dex. Also, update on DARA-based quadruplet therapy, Cassiopeia, that is DARA attached to VTD, Griffin, DARA attached to VRD, and Master, DARA attached to KRD. And of course, the Master Blaster, subcutaneous route of DARA. Imagine giving DARA in 5-10 minutes versus hours. Subcutaneous DARA got its approval a couple of months ago. The other breaking news included the other monoclonal, isatuximab, for newly diagnosed high-risk myeloma in combination with KRD. We talked about carfilzomib-based therapy, endurance trial, treatment of myeloma in COVID-19 era, and MRD assessment, which is also a master blaster. MRD assessment in field of myeloma is today ripe. MRD negative status as assessed by next generation sequencing or next generation flow is the best prognostic tool, and it supersedes revised ISS or even stringent CR, etc. Additional trials are needed to determine if changes in the treatment can be made guided by MRD status. We also need additional data to determine if MRD can be used as a surrogate endpoint for the regulatory approvals. And lastly, does sustained MRD negativity means a cure? If you want to know more about MRD in myeloma and other diseases, join us after 2 days, Sunday, 19th July at 11:30 a.m. for the MHG live webinar. Before I close, I bow down to Dr. Robert Kyle. If it was not for his efforts and vision, we would not have been where we are in the management of myeloma. Well, thank you so much for giving me this opportunity to speak to you.
Thank you very much, sir. This was an awesome presentation as usual. So we were all mesmerized listening to you, and I'm really thankful to you. And I'm very delighted to announce that Dr. Nupur Raje has joined us. I welcome Dr. Nupur Raje to this webinar. Thank you very much for accepting our invitation at such a short notice. I know that it's not easy to catch hold of personality like you, and we all are hugely obliged. So can I request you to start your presentation, please?
Sure. Thank you so much for having me. I really appreciate all of you having me. What I will do is share my screen, I guess, and that way you should be able to see my presentation. Uh, just give me a couple minutes. So are you able to see my screen?
No, not yet.
Not yet. Okay.
So Kalpesh, can you help her out? Kalpesh?
Yes, ma'am, sir.
Can you help her out?
Ma'am,
Yes.
have you opened your presentation?
I have, and I've set share my screen also. So
Yes, you have to select that window containing your presentation. Yes, yes, we can see your slide.
you
Yes,
can see my screen now, right?
yes, yeah,
Perfect. Okay, great. And you can hear me fine, right?
Yeah,
yes.
absolutely.
Awesome. Awesome. So thank you so much for giving me this opportunity. It's great to see all of you by Zoom. And what I was asked to do was talk about relapse refractory multiple myeloma. And it's always a hard act to follow Dr. Agarwal, who gave a really nice overview of what we are doing in the newly diagnosed space. So the good news in myeloma, as you all know, is we have a lot of drugs which have been approved. There's been a lot of excitement around the new drugs. And I think the most recent drug approval we have is for subcutaneous daratumumab. And we, in fact, have moved to switching our patients to subcutaneous daratumumab, which has been a real game changer in the management of myeloma. In addition to that, we have a lot of different treatment approaches for the relapse refractory setting. And I think before you pick treatment for patients with relapse refractory myeloma, it's really important to assess the patient characteristics and try and understand the nature of the relapse, the frailty of a patient, risk assessment of the patient, and then come up with the most relevant treatment approach. This is just a list of all of the different randomized trials that you have out there. And I'm really not going to go into the details of this because all of you have seen some of the data. But the bottom line is we are using combination approaches even in the relapse setting. So triplets are being used compared to doublets unless you have a very frail patient or patient is unable to tolerate it. There's the combination of IRD, there's the combination of KRD, and we are also using drugs like pomalidomide in combination with either bortezomib or in combination with daratumumab. Most recently, we've had selinexor approved as well. And selinexor is being used in combination with Selinexor has been used in combination with both bortezomib as well as in combination with carfilzomib in patients with myeloma. The daratumumab pomalidomide dexamethasone combination is FDA approved in the United States. We're using this quite commonly in second and third line treatment in our patients, and we do see a 9-month progression-free survival with this combination of about 86.3 months or so. Most recently, both at ASCO and EHA, we had the combination of carfilzomib with daratumumab, which was presented. This is the CANDOR study, which was presented, and the CANDOR study, as well as the IKEMA study, which I'll show you in a minute, shows very similar data, wherein you're seeing an overall response rate, which is quite remarkable, of 80+%, translating into a median progression-free survival, which has not yet been reached at a follow-up of about 15 months. Elo-Palm-Dex is being used. I will tell you that we don't tend to use elotuzumab as much because in the relapse refractory setting, it's really hard to find elotuzumab to be quite efficacious. This is the other study that I mentioned to you, which is the IKEMA trial, isatuximab in combination with pomalidomide and dexamethasone. Again, I'm sorry, this is the IKEMA study, isatuximab in combination with carfilzomib dexamethasone. This was largely done in the European Union, and very similar to what we saw in the US with the CANDOR study with MRD negative disease in a subset of patients, translating into a nice progression-free survival benefit. We talked a little bit about selinexor in the table form, but we have selinexor now approved, and selinexor is a novel drug which is a exportin nucleoprotein inhibitor. The STORM trial is what got its FDA approval, and at this year's ASCO, the Boston trial was presented, and the Boston trial actually confirmed the efficacy of selinexor in combination with bortezomib and dexamethasone in relapsed refractory myeloma. The problem with a drug like selinexor is the fact that it's not easy to tolerate. It is very hard on patients in terms of GI toxicity. We do see a lot of weight loss, a lot of nausea, and I think we're still working on trying to figure out what the best treatment, what the best schedule for this Boston trial is when you combine it with bortezomib. In the Boston trial, they used 100 milligrams of selinexor, but going forward, I do think we have to decrease the dose of selinexor. And typically, at least in my clinic, I use 60 milligrams of selinexor and not any more than that, specifically when you use this in combination. Other combinations are being studied, selinexor with daratumumab, selinexor with pomalidomide, and we'll wait and see as to what the responses of these are. But the initial data looks quite encouraging, specifically the combination of selinexor with daratumumab, where you have a median progression-free survival of a little over a year. This is just a whole host of different clinical trials in the relapse refractory setting, and I've just put them in together, and you can see the different hazard ratios. All of them are effective, all of them are combinations, and depending on the nature of the relapse of a patient, you pick one or the other combination in the context of relapsed refractory myeloma. Moving on now, I do want to spend a little bit of time on what's new out there, and I think we have a lot of new and encouraging drugs available for us in the relapse refractory setting. None of these drugs are approved as yet. All of these drugs are being used in the context of clinical trials. So these are drugs which are going to come down the pike and hopefully will be accessible and available to you all very soon. The ones which I want to mention right now are cell modulatory drugs, or the new cell mods. And the one which is furthermost in its development with cell mods is iberdomide. And iberdomide is even more potent than lenalidomide and pomalidomide. And if you look at the EC50 of iberdomide, it is several fold lower than that of both lenalidomide and pomalidomide. It binds to cereblon the same way that lenalidomide and pomalidomide do, and by doing so, it causes degradation of the transcription factors which are downstream, such as Icarus and Aiolis. Importantly, these also have immunomodulatory effects by secreting IL-2, as shown in this graph here. And the beauty of this is the efficacy of iberdomide has been shown, and it's been efficacious in patients who've had prior IMiDs. So they've been refractory to both lenalidomide and pomalidomide. And despite that, you're seeing an overall response rate of above 30% with the use of iberdomide. We have a newer drug now. It's the CellMod, which is 480. It's even more potent than iberdomide. And I think these CellMods, because they are oral drugs, they're extremely well tolerated, and they actually can be combined with some of our backbone drugs quite easily as well. So again, something which is worth looking forward to. We always worry about patients who have become refractory to lenalidomide and then pomalidomide, and the concern is always, what do you use next in terms of IMiDs? And we always found different approaches to these patients as well. Another drug which I did want to mention was venetoclax. Venetoclax, I think all of you have used in the lymphoma world, in the CLL world. We're using it in myeloma as well. It's a BCL2 inhibitor, and as all of you know, venetoclax can actually be quite effective in a subset of multiple myeloma patients who are BCL2 dependent, and that has largely been identified by patients who have the 1114 translocation. The Bellini trial was done. The Bellini trial is a trial which was comparing venetoclax with bortezomib dex and bortezomib dex and bortezomib dex plus venetoclax. Unfortunately, the Bellini trial had to be stopped early because of a survival disadvantage when they looked at all comers of patients. However, when you focus in on the patients who have the 1114 translocation, what was seen was remarkable responses in this 1114 translocated patient population. Now, this is the patient population which is BCL2 dependent. This is the patient population you're actually seeing MRD negativity. And going forward, I do think patients with the 1114 translocation have an alternative drug with venetoclax wherein it works quite well. And we did not see an overall survival disadvantage in this subset analysis of the Bellini trial. And if you look at the progression-free survival in this patient population, the median has not yet been reached in patients who have the 1114 translocation. I think, the most excitement, though, in the relapse refractory setting in multiple myeloma has been around BCMA as a target. BCMA is the B cell maturation antigen. And what you have here is it's an antigen which is expressed essentially on all multiple myeloma cells. There's different ways of targeting BCMA. We have antibody drug conjugates. I'm going to show you a little bit of data with that. We have the bispecific T cell engagers. And most excitingly, we also now have cellular therapy, which is CAR T cell therapy with multiple myeloma. So starting off with the conjugate, we have belantamab mafodotin. There was an ODAC advisory committee just 2 days back, and there was an overwhelming vote to get belantamab mafodotin approved in the context of multiple myeloma. The vote was 12-0 by ODAC, and this was largely based on this DREAM2 study. So belantamab is a conjugate with MMFA as the warhead. And if you look at this, the overall response rate in this patient population was about 30%, which translated into a median progression-free survival of close to about 3 or 4 months in this very refractory patient population. This is the patient population which has seen just about every treatment going forward. I think the big thing to know about belantamab mafodotin is the fact that you do get a little bit of ocular toxicity associated with this, as well as thrombocytopenia. People get corneal irritation with this, and I think we have to try and figure out how best to give this conjugated antibody, but nonetheless, very effective strategy, and it is an off-the-shelf approach. Other interesting approaches are BiTEs. BiTEs are conjugated antibodies, and these are antibodies, again, off the shelf, targeting BCMA. They also engage the T cells, activate the T cells, and can cause tumor cell kill by the activation of the T cell. This is preliminary data from the BiTE antibody, which is from BMS. You see an overall response rate once you get to the MTD of 6 to 10 milligrams of 90% with a bispecific T cell engager. And the most interesting thing here is you're seeing MRD negative disease as well as stringent complete responses in patients who get off-the-shelf bispecific T cell engagers. So really extremely encouraging results. And then most importantly, once you get to the maximum tolerated dose or the dose going forward in the phase 2 doses, this response is actually long-lasting, with patients responding for up to 9 months while on treatment. We've been involved, obviously, with the CAR T cell approach with myeloma, and the CAR T cell approach, I think the one which is further most in development is ide-cel or BB2121. We first did the phase 1 study. We saw 90% response rates in this, which translated into a progression-free survival of close to a year in, again, a very heavily pretreated patient population. The phase 2 study was presented at this year's ASCO in 128 patients. And the nice thing about this study was this was a global study, so it was not restricted to the phase 1 trial alone. Again, very high response rates, close to 80% plus, translating into a progression-free survival and an overall survival benefit, very similar to what we saw in our phase 1 clinical trial. If you look at patients who achieve a complete response, though, those patients at the target dose had a median progression-free survival of 20 months in this patient population. Other CAR T cells are also being developed in myeloma. This is the Janssen product, and this is the CARTITUDE trial, where you have an overall response rate of 100%. And although the median follow-up of this is a little bit less than that of what you see with ide-cel, at least at the median of 11.5 months, 22 of the 29 patients treated on the CARTITUDE trial remain progression-free survival. Again, quite remarkable data. Similarly, the JCAR product or the EVOLVE study was presented as well. The differences here are, this is called Orva-cel, and the difference here is that in the final product, you have equal numbers of CD4 and CD8 cells. And if you look at this again, response rates are extremely robust, north of 90% in all of these, all of them achieving MRD negative disease, translating into a progression-free survival, which is quite remarkable, and patients staying in remission for close to a year with this Orva-cel drug product. So this is just summarizing all of these 3 CAR T cell products. The bottom line is All of them are very similar in terms of safety. We have seen very little in terms of toxicity from any of these products, which is quite reassuring. And overall efficacy of all of these products is extremely high, with more than 90% of patients responding. And this is translating into progression-free survivals, which in the Karma study, as I've mentioned, if you achieve a stringent CR with your CAR T cell product, you see a PFS of close to 20 months in this patient population. So I think what I have tried to show you all in these last few minutes here is we do have a lot of different approaches that you can use for the relapsed refractory multiple myeloma patients. We have several new drugs that we are excited about. Venetoclax, for example, should be considered in the 11-14 translocated patient population. There is encouraging data with iberdomide and the newer CELMoD as well, specifically in patients who become lenalidomide and pomalidomide refractory. And BCMA is obviously a really promising target after you heard from Dr. Agarwal that we brought CD38 monoclonal antibodies in the upfront setting now. We are seeing a refractory patient population to CD38 approaches. That's a very difficult to treat approach, and using a BCMA target in that patient population, as you saw in the DREAM study, showing efficacy is really quite promising. And then the off-the-shelf approaches with the BiTEs and the other more personalized approaches with CAR T cells is resulting in quite remarkable efficacy and progression-free survivals of close to 2 years. So a lot of excitement around some of these new drugs. And with that, I think I will end. I'm hoping that you all were able to catch all of that, Dr. Bapna.
Yeah, absolutely.
And I'll stop there.
Yeah,
Thank you.
thank you so very much, Dr. Nupur. And this was a new knowledge for all of us. So probably we'll be using this knowledge in future in treating our patients of relapsed and refractory multiple myeloma. Fortunately, Dr. Advani is with us, and he has seen the whole journey of multiple myeloma in last 40 years. So, sir, tell us your experience and how do you feel that the scenario of multiple myeloma in 2020 in comparison to what you started with.
First of all, I must say that I feel today very proud that we had a really good time working with Dr. Nupur here in Bombay and at Tata Memorial Hospital long time ago. And today we are so proud of you that you have reached to the place where very few can reach. And I think it's your hard work and all has really given you all the achievements. So, but obviously, Dr. Agarwal and Dr. Nupur, both of them have really exposed all of us to the knowledge about not only the new approaches, but also new sequencing of the drug. And I think that's very important. It may be the old drug, but you sequence it rightly and you can get the better results. And of course, I think it is from 2000 onwards, every year we are getting one or two new drugs and new approaches. And today we could see that how we have 7 more approaches which are not yet approved, but may be approved soon to really deal with the multiple myeloma. I hope one day we can achieve cure or eradication, which is even with all the advances we have not been able to really achieve, but we are moving forward to it. And again, once again, thank you, Dr. Nupur and Dr. Agarwal, for giving us all the knowledge. Thank you very much.
Thank you very much, sir. And I request all the faculties to please remain logging. And there are a lot of questions. And I request my colleague, Dr. Upendra Sharma, to please coordinate the question answer session. Dr. Upendra, please. Kalpesh, can you help Dr. Upendra Sharma?
Yes. Hello.
Yeah, can you help Dr. Upendra Sharma out for the question answer session, please?
I think so. He is not audible, I think. is speaking something. Dr. Upendra, we are not getting your voice. Can you please remove your headphone? Hello.
Yeah, Upendra. Hello. So can I start asking the question? Yeah.
Yeah, let
So
him rejoin.
So there is one question by Dr. Avinash Upadhyay that patient after VRD 5 cycles had stringent CR and beam maintenance relapsed after 9 months after the VRD 5 cycles. Now on pomalidomide. So even with the 2 milligram pomalidomide was having the cytopenias. So what should be done in resource constraint world? Can we rechallenge with the VRD as she had stringent CR post 5 cycles VRD? So basically this patient is pomalidomide intolerant. So can I request Dr. Adya Agarwal sir to highlight about this query?
So relapse setting, may I request Dr. Nupur?
Yeah.
Sure. No, this is a common problem. But before talking about relapse, I think the important thing to remember for myeloma is, we should be continuing therapy. So don't stop at 5 cycles of treatment, even if they've achieved a stringent CR. I think the one thing we've learned about myeloma is continuous therapy is important, or maintenance treatment is important if they haven't had anything else. So continuing with the Velcade and lenalidomide at the lowest possible doses would have been the right thing. But in this case, absolutely, I think since they've been off of proteasome inhibitor for some time and have been off of lenalidomide, she's probably going to be sensitive. Going back to RVD would be perfectly reasonable, but then not stopping after they've achieved a response is the key. If, on the other hand, they do not respond, you do have the option of adding a monoclonal antibody like CD38, like daratumumab, with bortezomib as well. So lots of options here, but continuous therapy is critical in this patient.
So there is another question which is directed to Dr. Nupur Raje from Dr. Manoj Mahajan. He's a senior medical oncologist from Udaipur. So Dr. Manoj is asking that does copy number of 1Q changes poor prognosis imparted by its gain? And the second question is, does bortezomib and daratumumab and 4-drug regime in newly diagnosed multiple myeloma negate its poor prognosis? And continuation to this, he has also asked that if there is any evidence good enough to consider it prognostic marker, as most of the studies are done on very small number of the patients. So basically his question is about the 1Q gain, where the copy numbers matters or not, 1, 2, 3 or 4, or all are high risk.
So all good questions here, and I don't think we have all the answers. The fact that gain in 1Q is becoming more of a prognostic marker is real, and we are considering this as a high-risk feature going forward. Copy number does matter, and more than, it's a cutoff for that specific lab. We take more than 10 as considered, at least at our lab, but copy number absolutely makes a difference. With 4-drug regimens, the second question was, does it negate the high-risk features? The data that you've seen with 4 drugs, like the Griffin trial RVD with daratumumab, or Cassiopeia, which is VTD with daratumumab, we've seen very high response rates, 100% of people responding with high MRD negative disease as well. I don't think these are largely, the high risk patients are also doing fine. I don't think we've seen data to say the 4 drugs does better in the high-risk patient population compared to the 3 drugs as well. So the 4 drugs does negate some of the high-risk prognostic features. With the Griffin, we still have to wait because we've not been able to look at high-risk cytogenetics versus not. Responses are deeper for sure, but toxicity is also higher when you start combining so many drugs together.
Thank you very much, Dr. Nupur. Can I, Dr. Manju is logged in with us or not? Is Dr.
Yeah, ma'am is there, sir.
Yeah, Dr. Manju?
Yeah, I'm there.
Yeah. So there is one question from Dr. Dipti Rani Samantha that she has asked that what is the ideal maintenance therapy in transplant ineligible patient?
So again, we need to look at first, what's the reason for being ineligible? And, if it is not somebody really frail and it's just the age which is the reason, then in that case, one can still think of a triplet. That's what we would suggest. But if it is somebody who's frail, then in that case, doublet can be considered. And definitely we need to take in consideration whether it's what are the additional comorbidities and which are the drugs which are going to be, tolerated by that particular patient.
Okay, thank you very much. Can I ask Dr. Agarwal that what is the difference between daratumumab and daratumumab with hyaluronidase, FIHJ, and in considering the clinical response? So, sir, can you?
So basically, it is using daratumumab by 2 different routes. When you are giving it as intravenous infusion, it is dara alone. But when you are giving it by subcutaneous route, you have to give it with hyaluronidase. That's the preparation. It's a spreading agent. The huge advantage of subcutaneous route is the time-saving part of it. Something that you take hours, you're finishing in minutes. And of course, the reactions are also less. So subcute route is with hyaluronidase, IV is without hyaluronidase.
So, Dr. Upendra, are you online?
Sir, can you hear me?
Yes.
Yeah, you can continue, Dr. Upendra, asking the questions.
Sir, I'm really sorry. There
No
are some
issue,
problem
no issue.
with
Carry
this.
on.
So I have logged in with a different laptop. So
Carry on, please.
Sir,
You will start from the Vibhor Sharma. Question from Dr. Vibhor Sharma.
Vibhor Sharma. So this is question from Vibhor. How do you define refracting? This is question to Dr. Manju Sagar. How do you define refractiness to bortezomib and lenalidomide? For example, if a patient received 4 to 6 cycles of RVD, then he was transplanted, and then he received lenalidomide maintenance and relapsed down the line, can he still be labeled as refractory to bortezomib? So he received 4 to 6 cycles of RVD, initially bortezomib for 4 to 6 cycles, then transplanted, then received lenalidomide. So can once he is relapsed, can he still be labeled as refractory to bortezomib? Dr. Manju?
No, I don't think he's. Yeah, I don't think he's refractory to bortezomib. When we talk about refractoriness, it's a progression within 60 days from the last treatment, whatever is the last treatment ongoing. So here the RVD was given before transplant, and the progression has happened on len maintenance. I don't think that this is called as refractoriness to bortezomib.
Thank you. So another question from Satyajit Pawar. So question to Dr. M.B. Agrawal, sir. A 60-year female, multiple myeloma, revised ISS-1. She received 6 cycles of VRD and achieved stringent CR and planned for autologous stem cell transplantation, but this was delayed due to personal reasons. And she relapsed on lenalidomide maintenance received for 3 months. So now workup done, FISH is negative. She received VPD 4 cycles, and post VPD 4 cycles, she is in stringent CR. So what is the optimal consolidation strategy for this patient in this COVID era?
So if the COVID era is interfering with autologous transplant for her, you'll continue with the triplet for a total of 8 to 12 cycles. And by that time, I suppose you may be able to do transplant, but you will at least have the stem cells preserved immediately.
Thank you, sir. Thank you very much. Another question from Dr. Neha Ganju. This is question to Dr. Nupur Raje. In high-risk myeloma patients who are eligible for transplant, what is the upfront DARA-based regime? Is there is role of DARA-based regime in standard risk transplant eligible patients also?
So again, a good question. You know, the data for the transplant eligible patients with DARA include both Cassiopeia as well as Griffin. So the European study had daratumumab with Velcade, thalidomide, and XVTD. And the Griffin trial has DARA with RVD. So you can consider using either or. Right now, you know, I will tell you that even I'm not using 4-drug combinations outside of a clinical trial because I think the data with the 4 drugs is still early, and it does, you know, compound toxicity as well. And we are seeing very deep responses for sure. But does everybody need the 4-drug combination? It's a little bit unclear right now. Triplets are still working just as well. So RVD and KRD work fine. There may be a case made for the high-risk patient to add on the 4th drug, which would be the monoclonal antibody.
Thank you, Dr. Nupur. Now my question to Dr. Manju Sehgal. How do you evaluate relapsed myeloma? Again, from question from Dr. Neha Ganju.
So we actually, we monitor, so the relapsed myeloma can be just serological progression without having any of the end organ damage. So we need to evaluate for the end organ damage. We need to look at how the first presentation was based on, to decide whether you want to just treat on the basis of how the serological progression is happening, how rapidly it is happening. If you have the means, other than looking at the end organ evaluation, one should consider doing a marrow at this time and evaluating cytogenetics and FISH. So that's what we would suggest if you have all the means available to you.
Okay, thank you. Another question from Raj Kiran. This question to Dr. M.B. Agrawal, sir. For a case of 65-year case male, standard risk newly diagnosed multiple myeloma, transplant eligible, but unwilling for autologous stem cell transplantation. This patient has received 16 cycles of VRD and electrophoresis after 16 cycles showed good response. So what should be the next line of therapy?
So even if he's not willing for the transplant at the moment, I will still persuade him to store his stem cells. And then if the response is satisfactory and he's already received 16 cycles, I will now go over to the maintenance therapy. And if the response, this good response, I do not know what exactly it means, but if it is not a satisfactory response, I'll maintain him with low dose VRD, but maintenance therapy, yes.
Okay, thank you, sir. Now my question to Dr. Nupur Raje. This is question from Dr. Neha Ganju. Is autologous stem cell transplantation is indicated after CAR T cell therapy?
It's tough because we are doing right now, CAR T cells is happening at very end stage myeloma. So those are not patients who you would consider doing an autologous transplant. Having said that, we are now doing clinical trials early on. We are actually replacing autologous transplant with CAR T cells in high-risk myeloma. So high-risk cytogenetics, they can get initial induction followed by CAR T cells, and we'll see what that data looks like. We have not given autologous transplant post-CAR T cells as yet.
Thank you. Again, a question to you, Dr. Nupur. This is question from Dr. Akshay. Is there is any way to enroll patients of lymphoma, myeloma, or leukemia for CAR T cell therapy trial anywhere in the world? So how we can enroll our patients from India?
Yeah, so, again, good question. We do have a lot of clinical trials available. The problem is they will have to come here, and with what's going on with COVID, all restrictions apply all over the world. So that's not happening. But otherwise, we have treated people from outside the US on clinical trials. And I think in the COVID era, it's less likely. Having said that, I'm working very closely with an Indian company, Immunil, to try and get CAR T cells to the Indian patient population. And we are working for lymphoma as well as myeloma. And our hope is that we will get CAR T cells to patients in India.
So this will be the
Thank
last
you.
question.
Thank you very much.
Upendra, this
Yes,
should
sir.
be the last. This
Yes,
should be
sir.
the
This is
last.
the last question. Yes, yes. So this question is to Dr. Manju Sehgal. Again, question from Akshay. Any prognostic significance of different heavy chain myeloma, IgA, IgG, and IgM? Or there is any significance of uninvolved heavy chain levels? Are we getting this report in our gel electrophoresis report?
I think with the current prognostication systems, if you look at the subtype of different heavy chain myeloma, I'm not sure that it maintains its significance with the cytogenetics and the revised ISS. There is no clear data on that with the current prognostication. There is some suggestion in terms of this involved versus uninvolved heavy chain levels, but again, not something which is proven in terms of prospectively done clinical trials to say that what is its relevance.
So
thank you, ma'am.
With this last question, we come to the end, and my heartfelt thanks to Dr. Nupur Raje for sparing time out of your such a busy schedule. And in the same breath, I extend my heartfelt thanks to Dr. M.B. Agrawal sir and Dr. S.H. Advani and Professor Manju also for sparing time for this webinar on multiple myeloma. And now I hand over the mic to Mr. Manoj Kumar from IMTAS Oncology to conclude the session.
I think, sir, it's an honor and privilege to be to have the coordinator role along with the MICE team. Firstly, I would like to thank Dr. Ajay Wafna for giving us this opportunity and giving us this academic feast. All the leading experts in the field of myeloma, Professor Manju Sengar, Dr. M.B. Agrawal, Dr. Nupur Raje, and expert comments by Dr. Advani. I think it was an academic feast. I would also like to thank my team at INTAS for all the hard work, and team at MICE Ideas for all the hard work in terms of coordination, which was running almost for a month or so. So thank you very much. Have a wonderful evening. And for you, ma'am, have a wonderful morning. Thank you very much.
Thank you
Thanks
very
so much for having me. Appreciate it.
Thank you so very much. Yeah.
Thank you.
Thank you.
Thank you, sir. And we take your leave. Thank you, Dr. Upendra.